Good afternoon, everyone. Thank you, Alana, for the introduction, and thank you, everyone, for coming today to today's webinar on medication management. Medication management has always been something that I always put so much focus on, so I hope you all find this webinar very useful. So to start off, why medication management? It's because regardless of the condition, the same question always comes up, right? When do I take this? How many hours in between my dosing? And in some cases, the instructions can be very straightforward and the physician may even list the time. So for example, the 1 tablet 5 times a day, you can see that it's listed on what times you should be taking the medications, right? But then what does it mean when it's something like 10 tabs daily in divided doses as directed? What does that mean? So to answer this question, I will start with the medication that often is associated with these type of instructions. And of course, that's levodopa. So for this presentation, I'm going to do a run through of all the medications that are used in Parkinson's disease, so levodopa and the other medications. I'll just make it brief just so that we can focus on the medication management part, but just as a recap, just so that we're all on the same page again. So with levodopa, it's converted from levodopa to dopamine in the brain and then stored in the neurons. And essentially its role is to replenish the depleted dopamine. Often levodopa is combined with carbidopa or bensericide, and their role is to help prevent the conversion of levodopa to dopamine out in the periphery, so before it gets into the brain. And by helping prevent this conversion, it helps decrease the side effects that some may experience, such as the nausea and vomiting. So the main role there is just to get it into the brain. There are different formulations of levodopa and different combinations. So we have, of course, the immediate release levodopa, carbidopa. We have the controlled release. We have levodopa combined with bensericide to make prolopa. We have that combination also with entacapone, so the Stalevo, and of course the intestinal gel duodopa. The onset of action of levodopa. So how long does it take to start working? Generally, it takes about, for the immediate release, about 30 minutes or so to kick in. Whereas with the controlled release, it takes about 1 to 2 hours. So the difference between the different formulations essentially is that with the immediate release, when you take the medication, it releases all at once. Whereas with the controlled release, theoretically, it is the medication's being released slowly over a longer period of time to provide a nice and smooth distribution, right? But that's why, because of its kinetics or how it is formulated, it might release, or the onset of action might not occur for another 1 to 2 hours. But with that being said, the absorption can be erratic and not the ideal nice and smooth distribution. And the absorption can actually differ from person to person. So essentially, it can differ and it can also be delayed, right? So in cases with Parkinson's, as Parkinson's progresses, our gastrointestinal tract slows down as well, and it can cause us to have constipation. So in cases where we are having that decreased gut motility, so how fast things are moving along, when we have a decrease in that, it can actually affect how we absorb medications. So when you're thinking of a controlled release formulation where it's being technically, it should be slowly released, when we add that and take into account the decreased gut motility, it kind of, you can see why the absorption isn't as smooth and it's a little bit more erratic. So in cases where with controlled release, some individuals will say, oh, it looks like there is a delay. Sometimes it's 1.5 to 2 hours before it kicks in. Sometimes it just changes from day to day, right? So it's one of those things where we have to really focus on managing our constipation, especially because it ties in with gut motility, and it can affect how long it takes for our medications to kick in, as well as it can affect how long the effect of the medication like levodopa lasts for. So it's definitely one of those things. But with that being said, some people do quite well on controlled release formulation. Everyone's different, but yeah, so that's the controlled release. So in regards to how to take levodopa is actually best taken on an empty stomach, and it's best taken on an empty stomach because it actually helps increase absorption Usually I recommend 30 to 60 minutes before a meal or 1 to 2 hours after a meal. I put a little bit of a range there because different sources have, said different things, but generally I put the one in red where it's 30 minutes before a meal and 1 to 2 hour, 1 hour after a meal is absolutely fine. It just helps you with managing your day and allowing you to be able to do what you need to do without feeling restricted that you have to wait. So 30 minutes before, 1 hour after meals, totally fine. In regards to spacing from iron, it's important to space from iron because iron can actually bind to levodopa and thereby reducing the amount of medication that is absorbed by your system. So usually in cases like this, telling people to space it about 2 to 3 hours before or after levodopa, or 4 hours if possible. But it's just, you want to space it because you just want to not affect how much levodopa is being able to be absorbed by the bloodstream and taken to the brain. And the other thing, of course, is just making sure that you space your levodopa from protein-rich foods, because what happens is the protein from the foods that we eat and levodopa, they're actually absorbed at the same site, right? So they compete. So that's why you want to space it out so they're not competing to be absorbed, because if you take it with a protein-rich meal, the levodopa, then essentially you're not getting as much of the absorption, which of course would affect in that case the amount of time it takes to have that onset of the levodopa and decreasing its effectiveness. So that's why it's so important to space. So with the side effects of levodopa, so of course with nausea, some people might experience that. You can, of course, being mindful of taking it best absorbed on an empty stomach, but in cases where you are experiencing nausea for the first little bit, you can take it with, a handful of crackers, a slice of toast, or maybe some fruit, like half a banana or so. Some people might experience vomiting, orthostatic hypotension, so it's just that lightheadedness that some may experience when they're standing up from a sitting or a lying down position. We have confusion, we have hallucinations, and motor complications. So motor complication is broken down into motor fluctuations and dyskinesia. I've highlighted these concepts in detail on the first webinar, the levodopa one, but I'm going to do just a quick run through again. So with motor fluctuations, often we see that with Parkinson's disease progressing, the response to levodopa changes. So for some people, they can start off with 1 tablet 3 times a day, right, of the 100/25, and they find that the medication lasts for that long amount of time, right? They feel like, yeah, they're on, no issues, no problems doing the things that they need to do. However, as time goes on, you might find that the medication after, before it was lasting 5 to 6 hours, now it's like, 3 to 4 hours, and you're already beginning to feel as if you're beginning to slow down, right? So with that, that's a motor fluctuation, and there's different types of motor fluctuations. So wearing off, the end of dose effect, which I'll cover later in this presentation again, and then just the on-off phenomenon, dose failure, delayed on, and unpredictable off. And then another motor complication is dyskinesia. So dyskinesia broadly is referred to, or is defined as, the irregular, uncontrollable, involuntary movements, and it can affect different parts of the body. It can also spread as well. So in some cases, we'll see the different definitions of chorea and dystonia. Essentially, they're both forms, like chorea is one form and dystonia is another form of dyskinesia. So in regards to chorea, I remember reading somewhere, you think of it as almost, think of choreography. It is more fluid and dance-like. They're quick movements. So think of kind of the wriggling, the head bobbing, the fidgeting, the twisting, and the squirming movements. Whereas something like dystonia, it might occur first thing in the morning, right? When the dopamine levels are the lowest and you're feeling that your feet are cramped. You have those involuntary muscle contractions that can result in abnormal and sustained posture. So think of maybe when your head feels like it's kind of pulled to the side or towards the chest, it's those extended muscle spasms that some may experience. That is kind of more of the dystonia. But generally with dyskinesia, it is a side effect of some of the medications used to treat PD, but not a symptom of Parkinson's disease itself. And most often, dyskinesia is seen with levodopa. So the next class we're going to talk about quickly is the dopamine agonists. Of course, with the mechanism of action, they act on the dopamine receptors and they essentially mimic dopamine. Different examples include pramipexole, ropinirole, rotigotine, apomorphine, and bromocriptine. Generally, people associate the dopamine agonists are the side effects, which people have heard about. So the nausea, some people, orthostatic hypotension, so it's that lightheadedness when you're changing positions from, a seated to, or lying down to a standing position, that lightheadedness, drowsiness, leg edema, which is just swelling, fluid accumulation, and of course the sudden sleep attacks, the hallucinations, and the impulse control disorder. So along the lines of compulsive or excessive gambling, excessive shopping, binge eating, and hypersexuality. So those would be in the realm of impulse control disorders. And then the next one would be the MAO-B inhibitors. So with the MAO-B inhibitors, their mechanism of action is they actually help prevent the dopamine degradation or the breakdown in the brain, increasing the concentration of the dopamine that's inside. So essentially, by doing that, you're increasing the concentration of dopamine and helping it last longer. So examples of some MAO-B inhibitors include rasagiline, also known as Azilect, selegiline, and cefinamide. Some side effects with the MAO-B inhibitors include insomnia, hallucinations, nausea, dyskinesia, and orthostatic hypotension, so that lightheadedness. But with that being said, they have found that with the cefinamide, high blood pressure is more common. Just something to note if you're also on high blood pressure medication. And then we have the COMT inhibitors. So with their mechanism of action, what they do is they help reduce the levodopa clearance before it gets into the brain. So essentially, it helps prevent the levodopa from being broken down out in the periphery before it reaches the brain. So essentially, it extends the duration of action of levodopa. But in order for it to work, you have to take it with levodopa. It is not meant to be taken alone. So the COMT inhibitor I'm talking about is entacapone. And the side effects associated with COMT inhibitors include dyskinesia, nausea, diarrhea, urine discoloration. So orange and brown or in appearance, but it's nothing to be concerned about. And then we have our anticholinergics. So anticholinergics is postulated to balance the cholinergic and dopaminergic activity. So essentially, of course, just different neurotransmitters in our brain. And obviously, when something's out of balance, it's not favorable. So in cases like that, you might use something to help balance the cholinergics, which is our anticholinergics. Examples include trihexyphenidyl and benztropine. Often you will see anticholinergics used to help with tremor, and often it's used in younger individuals. And this is the case due to the fact of their side effect profile. So you can see that, side effects include dry mouth, blurred vision, urinary retention, constipation, drowsiness, and confusion and memory impairment. And you can see the ones that I've bolded there. Those are the ones that are definitely concerning in our older population, right? Not the most favorable. That's why they are generally used to treat a predominant tremor in younger individuals and possibly in earlier PD. And then we have the NMDA receptor antagonists, so also known as one common one would be amantadine. And amantadine, the mechanism of action is unclear, but it's believed to increase dopamine release and inhibit dopamine reuptake. So its role here is to help possibly reduce dyskinesia. And some people find that it may help, especially if they already tried to modify their existing Parkinson's disease medication regimen and it just wasn't sufficient. We might be adding amantadine to the regimen. With that being said, there are some side effects that we have to be concerned about, and it's because amantadine has those anticholinergic side effects, like the anticholinergics that I just spoke about. So possibly the confusion, right? Another side effect would be, in this case that pertains to amantadine, is insomnia, Some people might get dizziness, hallucinations. We have ankle edema, so it's just that swelling around the ankle, and often it's this side effect. If it does occur, it would limit treatment, and often it will be discontinued because that is not a side effect that you want. And then you have livedo reticularis. Essentially what this is, it's a net-like appearance. It's a modeling of the skin. It's a lacy and purplish discoloration of the skin, and it can occur on the legs. But it's one of those things that is reversible after you discontinue amantadine. And yeah, so those are the classes. And then, so now that we have all the medications and we did a recap of, levodopa, the dopamine agonists, and entacapone, etc., we're going to put it together. Hopefully I got your gears turning right now on where I might be going with this. So before we start, though, I just want to make sure that we're all on the same page in regards to the terminology, because of course when I talk to those with Parkinson's disease and I'm trying to help them manage their meds, it's just making sure that we're all using the same language when we actually talk about it, so that we can manage the medications and move things based on what an individual is experiencing. So of course with wearing off is also known as the end of dose effect, and this is when your medication effects are beginning to fade. So this is like what I said before, where before you were able to take 1 tablet 3 times a day, and now you're at the point where maybe you find that you're not getting that long lasting effect anymore, and you're finding that you're beginning to slow down a bit after 3 to 4 hours, and now it's looking like it's more 2 to 3. So that's the wearing off. And you find that your symptoms are returning before your next scheduled levodopa dose. And then we have an on state. So when we're on, our medication has kicked in, right? Our levodopa has kicked in, we're ready to go, and we have improved mobility and function. So things like getting ready for the day, buttoning up your shirt, right? Brushing your teeth, brushing your hair, prepping breakfast, those things are easier at this point, just doing things around the house. Whereas when you're in your off state, medication effects have worn off and your PD symptoms are beginning to return, so you are slowed down. It's as if at this point, you need a dose because you're off. So to talk about those different states and why, motor fluctuations might occur, especially the end of dose effect rather, is because as Parkinson's disease progresses, the number of neurons that are able to store and reuse the dopamine decreases. So it affects the length of symptom control. So of course, in that case, right, you're not taking 1 tablet 3 times a day. It's not sufficient anymore. You're at a point where you're like, I think I might have to, talk to my doctor about increasing to maybe 1 tablet 4 times a day because of the wearing off and the changes that's happening in the brain. So at this point, the time between the doses will decrease as well, because at this point you have to increase the dosing frequency to help manage the wearing off so that you have more control of your symptoms throughout the day. So the next slide, some possible methods that your neurologist or your movement disorder specialist might talk to you about wearing off. Some possible methods they might initiate is, like what I said, just increasing the dosing or the dosing frequency of the levodopa. So maybe 1 tablet 3 times a day to 1 tablet 4 times a day. In some cases as well, it really depends on what the needs are. They might even increase the dose as well in addition to increasing the frequency. It really depends on the circumstance. And then in other cases, to help with wearing off, we might be adding a medication from another class, right? So we might be adding entacapone. And like I said before about the entacapone, you would add something like that to help prevent the breakdown in the periphery before it actually reaches the brain. So of course, in that case, it would help wearing off in that regard. Or we might be adding a dopamine agonist, which can be used for motor fluctuations like wearing off. Or we might be using a MAO-B inhibitor. So the MAO-B inhibitor, like I said before, it helps prevent that degradation of dopamine in the brain. So in that way, it would help wearing off. So in some cases, you're adding just medications in different classes to help extend the pretty much those symptoms so that you have no wearing off, or at least, you're just trying to manage it so that your levodopa lasts longer. Or in some cases, I know what I said about that, immediate release and controlled release, but technically, theoretically, to help manage wearing off, you can also switch from an immediate release to controlled release formulation, and some people do well on a controlled release formulation. So the other motor complication that we have to address when managing medications is the dyskinesia, right? And that can often help because by changing your levodopa dosage or how often it's taken, you can actually help in that way manage your symptoms, right? Because the main thing is that when you're adjusting levodopa, you want to make sure that you have enough to control your symptoms, but not too much that it causes dyskinesia. So it's one of those things, for example, like how would I explain it would be, say for example with dyskinesia, right? You're taking one tablet 4 times a day, and one tablet 4 times a day, it's giving you some dyskinesia. So in that case, when you will try to bring it down to maybe 1 tablet 3 times a day, but then at that point, you're not passing that threshold and you're not getting good symptom management. So in some cases, you might just have to maybe increase the dose a bit, but then add amantadine to help manage that. Or how else could I think about it? Is like, say for example, here, this might be a better one. Say for example, you're taking levodopa, carbidopa, 100/25, and you're taking 1.5 tablets 4 times a day. And in some cases, in that case rather, you're experiencing dyskinesia. But then in the case where you try to bring it down to 1 tablet 4 times a day, you're not hitting that threshold, so you're still feeling slow, you're not getting good symptom management. So in that case, obviously a decrease to 1 tablet 4 times a day isn't sufficient. So in some cases, what people might have to do if, adjusting to a smaller dose of levodopa, if that's not sufficient, we might have to add something like amantadine to help with the dyskinesia, because as I discussed before, amantadine is an option to help manage that. So in cases where smaller doses of levodopa more frequently isn't an option, amantadine is. But for some people might find that by just taking the smaller doses, so instead of saying 1 tablet 3 times a day, if they're taking half a tablet 6 times a day, they might find that it's useful and helps manage their Parkinson's symptoms without the dyskinesia. Everyone is so different in this regard, and it is one of those things that you really have to talk to just a neurologist or movement disorder specialist just to help different ways that we can manage dyskinesia. Another thing is we could possibly add a dopamine agonist, and in some cases the stopping of entacapone or stopping a MAO-B inhibitor, which are known to, of course, help with wearing off, because essentially one is preventing, the entacapone is preventing that breakdown in the periphery, so outside before it reaches the brain, and then you have the MAO-B inhibitor, which helps, prevent the degradation or the breakdown in the brain. Stopping those might be required. And of course, with dyskinesia too, what I said about the controlled release and the immediate release, right? With the controlled release, it has more erratic absorption, right? Whereas with the immediate release, generally, it's pretty consistent. Like for the most part, if you're being mindful of what you're eating and, mindful of your protein intake away, you're mindful that you are taking the levodopa on an empty stomach, generally it's fairly consistent with the immediate release. So, and also with the immediate release, we're able to split the tablets as well, right? So we have more control in a way of our dosing. So now thinking of all this, right, and seeing the different ways of managing our medications, you may be thinking, what are my current Parkinson's disease medications and what can I do based on the medications that I have? And often it's just optimizing your current medication regimen. And in this case, where we are right now, where a lot of our phone consults are done, like our consults with our doctors are done over the phone and everything. And before with our appointments too, we just think about what can we do ourselves, and just to make sure it really is optimized before we go and see our physician to discuss our changes in how we're responding to our medications or changes in how we're doing, right? So usually I tell people when I sit down and we're talking about managing medications, this is actually the step-by-step process that I use. And it's pretty much one of those things where I get them to write down the time that they're taking all their medications, Parkinson's disease medications, as well as any other medications that they're taking. I get them to write down all their medications and always include for me the approximate meal times, because it's so much easier to see that visually and knowing how to go from there. It's just having the pen on paper and you can move things around. You can see what you're doing. And then often I will ask my patients, are you experiencing any side effects? Is it due to your Parkinson's medications, or is it possibly due to other medications? And of course, in this case, you want to make sure that you ask your pharmacist, just so you know what may be the cause of what. Another thing, of course, I would ask is when they are taking levodopa, right? I ask them, when is their medication kicking in? And when are they experiencing wearing off? So often I will, of course, add on to that, how long are you on for? And when do you start slowing down? What are those parts of the day that you actually kind of see these changes? So, and of course, in this regard too, I know it changes from day to day. So that's why I have them write down for me, like what a different day, like maybe a day where you're exercising versus just, a day where if you didn't get that much sleep, or there's a lot going on, like, because those can actually change different factors as well. So I always kind of get multiple days, just so we can have kind of a more well-rounded look. And of course I ask if my patients are experiencing any dyskinesias, because at that point, that's where we might have to make some adjustments based on what we have and what we're working with. But the main thing is that writing it down helps you keep track of what works for you and what does not. So I'm not expecting individuals to write down every day, but say, for example, if you do have an appointment coming up, if you're able to kind of just have a kind of a notebook that just tells you this has been working really well and this does not, it just helps you, and that it helps you, and it helps that conversation that you're going to be having with your neurologist or your movement disorder specialist, right? Because then you can see it visually and you can see, like, oh shoot, I think I'm just eating a little bit too much food before the summer, too much protein, or maybe it's just that, milk in your cereal that's really affecting, the onset of the levodopa. It really helps keep track of things visually. So going forward, I made some patient cases and we're going to go through them together. So my first case is going to be Alice. So Alice tells me that she's taking levodopa carbidopa, the immediate release formulation, 100/25, and she takes 1 tablet 3 times a day. When I ask her about her regimen, she tells me that she takes 1 tablet at 8 a.m., 2 p.m., and 8 p.m. So, and she has her breakfast at 8:30, lunch at 12, and dinner at 5:30. So when I look at it, I'm like, excellent. She is taking her levodopa tablet half an hour before breakfast. She is having her lunch. There's a spacing of 2 hours there, which is also good. And you can see the spacing at dinner and her evening dose as well. So, good. There's no issues there with that regimen. The next case would be Brian. So Brian tells me that he's taking the immediate release tablets too, 100/25, and he takes 1.5 tablets 4 times a day. He also takes pramipexole, 1 tablet 3 times a day, and then he takes amantadine, 1 capsule twice a day. So based on this regimen, I can see that Brian's issue here, he might be experiencing some dyskinesia based on the amantadine as well as the usage of pramipexole. So with Brian's regimen, he tells me that he takes his levodopa carbidopa IR tablet at 7:30 in the morning, 11:30, 3:30, and 7:30. So there's some good space and even spacing around there. And then he takes his pramipexole at 7:30, 3:30, and 10:30. And he takes his amantadine at 7:30 and 12:30. And then when we're looking at his meal times, I can see that he's having breakfast at 8, which is good because it's half an hour after his immediate release tablet in the morning. I can see that he's having lunch at 12:30, which is good because, again, it is 1 hour after he's taken his levodopa tablet, and he's having dinner at 5:30, right? And he's not taking a levodopa tablet until 7:30, and you can see the 2-hour spacing between the 3:30 and 5:30, and then the 7:30 and 5:30. So there's good spacing there. My main counseling for Brian, though, is that he should take all his amantadine doses by the middle of the afternoon because, like I said before, with amantadine, the side effects could be insomnia, right? So in some cases, this is going to be 7:30 and 12:30. But in some cases, if it's 1:30, 2:30, some days are better than others for Brian, those things can change too. So there's always a little bit of flexibility, but just being mindful of the amantadine there. And then we have our third case, and that's Kathy. So Kathy's shown me her medication regimen, and I can see that she's taking the immediate release tablets, 100/25. She takes 2 tablets 5 times a day. She takes a controlled release 200/50 tablet once daily at bedtime. She takes Entacapone, 200 milligrams, and she takes that 1 tablet 5 times a day. And she takes a Rasagiline tablet, 1 tablet once a day. So I can see, based on her regimen, her issues here might be wearing off because of the Entacapone, and then we have our MAO-B inhibitor, the Rasagiline. So when I go through her regimen, she tells me that she's taking her 2 tablets at 7:30, 10:30, 1:30, 4:30, and 7:30. She takes a controlled release tablet for bedtime at 10:30 to help her through the night. She takes an Entacapone tablet at 7:30 in the morning, 10:30, 1:30, 4:30, and 7:30. And you can see that, oh, perfect, she's taking it with her Levodopa tablets, because those are meant to be taken together, because the role of Entacapone is to essentially have it so the effects of the Levodopa can last longer, because it's preventing that breakdown in the periphery before it gets to the brain, so that more Levodopa can get into the brain. And then she takes a Rasagiline tablet at 10:30, and she has breakfast at 8, 12 p.m., and she has breakfast at 8, lunch at 12, and dinner at 5:30. So when I'm looking again, good, there's the spacing between all the meal times, right, and her Levodopa dosage, because there's at least half an hour break between the breakfast and the morning tablet. I can see there's good spacing around lunchtime, and there's good spacing around dinner as well. So the counseling points, she's done them. She's taking her Levodopa and her Entacapone together, and she's taking her Rasagiline in the morning. She doesn't have to take it right at 7:30, but taking it at 10:30 is fine, because you're still in the morning, and we're still being mindful about the side effect of insomnia. So in addition to the patient cases, and now that we're talking about managing medication, some other counseling points and questions that I've received in the past is, what do I do if I miss a dose of Levodopa, right? And often a lot of people might know, they know exactly when they're beginning to feel wearing off, and they know that, it's like clockwork. I know I have to take my Levodopa dose at this time. But say if we're in a case, you're out and about, and it's like, oh shoot, I don't have my dose with me, it's out, I'm at home. So generally it's one of those things where you can take that dose as soon as you remember, as appropriate, right? So if you are, for example, you might be too close to your next dose, at that point, you missed that earlier dose, right? You're just going to take your other dose that is due soon instead. And some days you just might miss a dose. But in cases where the timing, there's still enough hours in the day, you just have to move your subsequent doses accordingly, so that you're still getting, if it's the 1 tablet 3 times a day, it's still going to be approximately every 1 tablet every 6 to 8 hours. So you just do the best you can. I've also spoken to individuals, this doesn't affect everyone, but for some people might find that exercise might actually cause one to use up or burn through their Levodopa dose faster. So essentially, if you're using up the Levodopa dose faster, you might feel that the effects of the Levodopa dose isn't lasting as long. So on days where you might be engaging in strenuous physical activity, you might require a slightly shorter dosing interval, or an extra dose of Levodopa on those days. So it's just something to be mindful of. Some people, like I said, they don't have this issue, and they take the Levodopa dose in the morning, and then they're able to go a couple hours later to their kickboxing, or just their swimming, or their bike ride, or they're able to do some weight training. So everyone's different, but for some people, if they do experience this, that's where we just might have to shift our dosing interval. So instead of maybe taking 1 tablet every 4 hours or 5 hours as you were before, you might have to take it every 3, for example, because you are burning through your Levodopa dose faster. And going back, of course, just as a pharmacist, right? And going back through what I said before about the dyskinesias and the wearing off, just do not stop taking a medication unless directed to do so by your physician. So in this case, right, if you can't talk to your neurologist right away, in this case, you might be talking to your family doctor about it, right? And of course, just say, these are the side effects I'm experiencing, in the case of maybe like hallucinations or extreme drowsiness or a side effect that's really affecting your quality of life. Make sure that you don't stop taking a medication unless you have consulted with a physician. And, in some cases as well, for my experience as a pharmacist, when I have that rapport with my patients, they'll come to me and tell me, oh, I'm experiencing this side effect and it's really making me, groggy. It's really affecting my quality of life, et cetera, et cetera. In that case, I might be the one contacting the doctor. Or if I ask the patient and they're telling me that, oh, I actually have a phone consultation with, so-and-so coming up, I might be, just calling that physician's office or just sending a fax just to notify them, hey, I spoke to so-and-so and they brought up this concern with me, so I just wanted to bring it to your attention since I know you're seeing them soon or you're going to be on a phone consultation with them soon. So just always making sure that there is a communication there and making sure that, someone is aware with just the changes or the things that are troubling you in regards to your medications so that you're not just stopping and that no one's aware of it. Okay. And then going back now into just the other concepts, right? Like with those sample patient cases that I made, those people, it was like clockwork when they were eating, when they were taking their medications, but of course there's always flexibility. And, once we're able to reconnect with our friends and family again, we have to kind of remember that our medications, they're not so rigid and we can be flexible with them. Because in the past, I've had people come to me like, what if I have like last minute plans to go out for dinner? Or what if I'm going to a friend's place this evening? Or what if family's visiting from out of town? We're going to be walking around a lot. We're walking around, the gardens, or we're walking around downtown. And in every situation like that, I always tell people to be flexible with their dosing when they need to be and having a dose or two in pocket. So just that image there is just, one of those kind of pill containers that you can put like a couple tablets in, 3, 4, or 5, whatever you need, just so that you have it on hand whenever you need. Say, for example, if you're going to be, at a friend's house or a family member's house in the evening and things run a little bit later than usual and, you're feeling like, oh, I'm going to miss my 8 p.m. dose, for example, because we're going to be here till 9:30, making sure just having just that extra dose or two of medication so that you don't have to go home sooner and you can still engage with your friends and connect. In cases where before we'd be talking about dinner, what do you do in the case where you have some people call you or you want to be spontaneous and you want to have dinner out tonight, right? So in a case like that, say, for example, you're told, why don't we meet at the restaurant at 6:30, right? And it's already 5:45. In that case, you can just take the medication before leaving the house. You can take the medication, just en route in the car if your partner's driving, right? Or your friend's driving. Because by the time you're seated, by the time you get the menus, by the time you actually have the first drink, that might be close to half an hour at that point. So you're still going to be taking levodopa on an empty stomach. So just being able to be flexible and just being mindful of that. Some days are going to be better than others, and that's okay. So what I did here was I just had like different tools that are available in the pharmacy. So as you can see on the bottom right hand corner there, we have the blister pack that you might see. I just have the arrow here, the blister pack of medications that we can do that your pharmacy can actually do for you. So of course, in that case, it might be useful for someone that might be taking levodopa, carbidopa, 1 tablet 4 times a day, because of course, that with the tablets, you can see that these blister packs are configured for Monday to Sunday, and then you have the morning, the midday, the early evening, and bedtime. So it's a 1 tablet 4 times a day, and then it's just all organized for you by the pharmacy. But in some cases, you might be able to do it yourself, not a problem, right? So that's where you can use an aid such as this. You can get one of these plastic containers that are also available at most pharmacies, where it goes from Sunday to Saturday, so a week again, and they all come in different colors for each day of the week. And again, if you're a person that's taking a medication 4 times a day, that gives you the flexibility there. But I was also thinking about, for example, I know some of my patients, they might be taking medication 6 times a day, and in some cases they might need a dose in the middle of the night, or just an as needed dose possibly before exercise. So what I did was I actually took, so I'm going to be pointing with my arrow at this one right here, where I kind of wrote it myself. So what this was that was one of those little plastic dosette containers, except it was dosed for, like, this would be technically for a week, and one row would be for morning and one row would be for evening. What I did instead was I just used little stickers, right? And I said, like, okay, say for example, a patient might be taking their medication every 3 hours. So I did 7:30, 10:30, 1:30, 4:30, 7:30, 10:30, and then just an as needed dose, because some people might find that they have to take a dose in the middle of the night, for example, at 2 a.m. when they're waking up and they're feeling stiffness, and trying to, adjust their sheets or change positions might be difficult. So that's where they might take, or that's what might be where they add their just immediate release tablet for their evening dose in case that they need it. And of course, you can see that what I did was, because this is technically one day, there's going to be a second day here, and I just kind of used a different color so that if I was to take this, I'd be like, oh, today's Tuesday, I'm going to be using the red row today, and then Wednesday is going to be the blue row. So it's just, I just did it just to help with, memory, and just to know which week I'm on, or which day I'm on rather. But of course, like I said before, these times can change, right? So the moment, I'm not really much of a morning person and I'm shifting it to 8:30, then I just take off all these labels and then I will relabel them again. So I think that could be a tool some people might find helpful, but yeah. So hopefully, going through this presentation now, you can hopefully have a better understanding of what it means when you see the different instructions. When you see 1 tablet 3 times a day, it really is catered to you. 1 tablet 4 times a day, also catered to you. And in the case where it's 1 tablet 5 times a day, those times can change, right? It can change based on how your symptoms have changed, or it can change based on the fact that, you're not really a 7 a.m. person anymore. Now things are just shifted maybe closer to 8, 9, and then you just have to shift everything else for the rest of the day accordingly. So things can change and you can adjust. In cases where it's 1 tablet 6 times a day, you know exactly what the regimen is. And then for some cases, it's 10 tablets divided daily, where you just have the 10 tablets and you just kind of break them up for what you need. So generally, of course, you can see with this presentation, medication management, it really comes down to you and what your needs are, and being able to write it out, see it visually, and thinking about when are the effects of the medications kicking in, and when am I wearing off? Where am I taking my protein? Am I making sure that I'm taking my iron separately? What days are a little bit more challenging? Am I starting to feel tired and a little bit more restless in the evening? Am I beginning to fade around 7 p.m.? What are the things that I can do? And does it tie in with my medication and how I'm taking my medication? So just, it kind of makes you think more about the things that you might be able to change in between those appointments with a neurologist or a movement disorder specialist. Just looking at what you currently have in your medication regimen and seeing if you can optimize it to help provide you to be more comfortable and better symptom control. And so with the take home, I pretty much just said it, but essentially the treatment is always tailored to you and your symptoms, and you're choosing a dose that works best for you. So a dose that would be best for you in most cases would be good symptom management with minimal dyskinesia, and always just kind of being mindful of the timing of the doses to match the response duration. So this is when you're writing out how long in between doses, or when the effects of the medication are beginning to fade, so that you can time accordingly. In some cases, if you're experiencing wearing off, it might involve increasing the number of doses per day, for example. But the main thing is, when we are making these medication adjustments with our levodopa, right, we always want to make sure that we're communicating this with our healthcare team, because we want to make sure that you keep us updated in cases where, you might not be seeing your neurologist, as frequently as your family physician, and you might be only seeing them every 6 to 9 months, as long as you're communicating with your family doctor, right, of some of the changes that you're going through, and maybe that might allow you to have an appointment with your neurologist or your movement disorder specialist sooner, for example. So just making sure that you communicate with us, and of course we'll always try to advocate for you to make sure that if you need care, you know, as soon as you can, or we'll see if we can make it happen. We'll do the best, but it's just as long as you're just communicating with us, just so we know what the update is and where we can help. And that is my presentation about managing medications. Yeah, if you guys have any questions. And this is me, this is my website, and if you have any comments on the presentation or maybe possible topics for the future, please send them my way. But I do hope that you find this presentation was